thank you so much for joining today. And we're really going to have an awesome conversation with our guests here. We're standing at a really pivotal moment in California's healthcare history, where as we come out of hopefully the worst stages of the COVID pandemic, and also seek to address what were revealed to be profound and longstanding equity issues, while transforming Medi-Cal across the whole state, one of the big questions that's come up is how can we be sure that we have the systems and the data and the governance in place to really share clinical data so that all of these critical health goals can be achieved in a really timely way in the next couple of years. So this question of how we can prepare our state to move into a world of much more robust and widespread data sharing is very much on everybody's minds. It's especially on our minds because we have a statewide conversation going on about a law called AB 133, which will require this kind of data sharing by 2024 for many providers. And also, again, as I said, as we talk about CalAIM and its rollout, which is going to require a much greater integration and coordination of care across the state. So what's great is people often say that the future is here, it's just and unevenly distributed. And I would like to say that the Inland Empire represents this future that we're trying to get towards, in the sense that they have been a leader in really cultivating a culture and an actual pragmatic, practical, operational health information exchange for many years. And this has taken a lot of hard work by many partners, those partners including the health systems, the small practices, and the health plans in that area. So what we'd like to do today is really give the stage to our Inland Empire colleagues to help us really understand what that took, what that's enabling, and how we might replicate those successes across the state. So I'd like to briefly introduce our three panelists, and I'll also just say a word about myself. Then we'll do a couple of housekeeping items, and then we'll jump into the conversation. So let's start. What I'd like to do is ask each panelist to introduce their name and their role, and just a minute or so about their organization and what their role is in the Inland Empire. And I will start with Dolores Greene.
Good afternoon, everyone. I'm Dolores Greene, and I wear a couple of hats. I'm the executive director with the Riverside County Medical Association. I serve as the CEO of the Inland Empire Foundation for Medical Care. And then I am also on the board of the Inland Empire Health Information Organization, which represents the stakeholders here in the Inland Empire to the statewide HIE. And my last role I do want to disclose is that I do serve as a board member on Manifest MedX. Thank you, Claudia.
Thanks, Dolores. Let's go to Dr. Juhn next.
Hi, everyone. It's a pleasure to connect with you all virtually. My name is Ed Juhn, and I'm the Chief Quality Officer here at Inland Empire Health Plan. Inland Empire Health Plan, also referred to as IEHP, is a top 10 largest Medicaid health plan and the largest not-for-profit Medicare Medicaid plan in the country. We currently serve about 1.5 million members in Riverside and San Bernardino counties. We have over 7,000 providers that are working on allowing our communities to enjoy optimal care and vibrant health. And for more than 25 years, we've worked really hard to improve access to quality and affordable healthcare. And our guiding principle is to put the needs of our members first. So thank you for having me.
Thanks, Dr. Juhn. And Judy Nightingale.
I am Judy Nightingale, and I'm the Director of Population Health for the County of Riverside. My background is in nursing administration, and currently I've got the oversight for all of the CalAIM individuals in IEHP and in Molina. And formerly, those two groups were the Whole Person Care Project, which was a transition out of incarceration effort. And secondly, the Health Homes Program, which was a focused assistance to people with chronic and complicated health conditions. Thank you, Claudia.
You can see we're in amazing hands, and we're going to have so much to learn from this great panel. My name is Claudia Williams. I'm the CEO of Manifest MedX. We are a statewide health information sharing network. We're very proud to partner with these great folks in the Inland Empire, and we'll be talking more about the work we've been doing together. So all lines will be muted. We would love to have your questions. We'll have time for Q&A at the end of the session. So please use the Q&A button at the bottom of your screen to enter questions at any time, and then we'll be circling back to those at the end. The session will be recorded and will be available to you by email and on our website afterwards. So those are just a few housekeeping items before we get going. All right, let's get this show on the road. So when I joined MX 5 years ago, Dolores, I had such a pleasure to meet you and hear the story of how this important work got started and what it took to really get it to the stage it was then and the stage it is now. So I just, as a extraordinary leader in the Inland Empire and someone who was really, like they say, there from the beginning, can you tell us a little bit about the history and what it took to get that kind of collaboration and engagement going early on?
Okay, thank you. As I like to say, we've come a long ways, baby, because we started our HIE discussions back in late 2009, 2010. And so we began the discussion, and at that time, not many people even knew how to spell HIE, let alone, what it was all about, and people had different concepts of what it would be. So we spent about a year really bringing together the healthcare stakeholders in the Inland Empire, and there was a lot of concern, reticence about sharing data, protecting the data, all of the things that I know all of us on this call have experienced in one way or another. And so we spent a year actually educating our community, learning from others who have had either started successful or the failures too. We wanted to really know what it was all about. But what we did is we brought together, IEHP was at the table at the very beginning, the Hospital Association, and then of course the Medical Association. So we brought, the key stakeholders together to have the conversation. And then in 2011, our group said, okay, we're ready to do it. One of the biggest mistakes I say of my 42 years now with the Medical Association is back when the ACA was first formed and the ONC funded the EHR projects to help physicians implement an EHR and reach meaningful use. We were part of that, and we helped close to 800 providers in the Inland Empire implement an EHR. Had I known then what I know now, we would not have said, here's a choice of 20 or 200, pick the best ones for you. And the criteria of picking the best one for physician offices was very difficult. And so it came down to personalities and all of that. Had we known then, not to introduce 200 different EHRs and really kind of focus, but we didn't. We had learned lessons. So after about, a couple of years of the EHR implementation, we realized that we created a monster in that none of these systems talk to each other. And hence, the discussion with the HIE was brought about. So in 2012, with all of the stakeholders around the table committed to a self-sustaining model, which meant you had to pay to play, we had to support this somehow. We did stand up the Inland Empire Health Information Exchange in 2012. But then, as we all know, data projects are extremely expensive. And we were at the point 2 years later that we needed to make a significant technology change to move with the future and the size that our HIE had gotten. But then an opportunity presented itself in late 2014 to partner with another HIE that was a very different model than ours. But we recognized that to be able to grow the HIE and to have the type of technology that was needed, it had to be bigger than the Inland Empire. So by partnering, we then formed Manifest MedX that we're all here today. And that really gave us the opportunity to take the HIE in the Inland Empire and move it to the next level. But by that time, we had a large number, not a majority, but a large number of the hospitals exchanging data, the large medical groups. And then we started focusing on nucleuses within communities. And that's how we were able to build the robust HIE. It wasn't a shotgun approach, but it was really looking at the communities, and the Inland Empire is huge. So we would focus on a hospital, the surrounding physician community, and the surrounding ambulatory community, and built it and did that in each of the communities. And then we didn't have 100% participation at the time with hospitals. Again, lots, for various reasons. IEHP then stepped to the plate, and I'm not going to take Dr. Juhn's kudos. He can do that himself, but they implemented their incentive program. And that took us over the bridge, if you will, to really bring together and have real-time data from the hospitals, which then benefited the remainder of the community.
And I'd say, just a little commentary, I'd say the great thing now for communities that might be tuning in and thinking, oh my goodness, do I have to wait 20 years before I get this? Is there are partners across the state to serve every community. So it's still great that community engagement is critical, but it's not like you literally have to go through those same journey steps of like building it again. There are partners that are there to help you get to the same kind of accomplishments I think we've seen in the Inland Empire. I think it speaks to a shared trait, which is persistence, Dolores, that you and I have. It takes a lot of persistence to get this done. And Dr. Juhn, you are in a new role. The IHP is such a gem in the California healthcare marketplace. And this new role of being really the leader charged with improving quality, you've often said that there's an essential bond between those quality goals and sharing data. I'd like you to just describe a little more how you see that and why those two things are like peanut butter and jelly together.
Well, I think it's important to call out that IHP continues to refine our path to improve quality as an enterprise. In service to this, we've actually developed a new framework that focuses, I would say, more on a holistic application of quality by connecting our approach to quality ratings and performance with our approach to healthcare delivery, with our approach to data and analytics and approach to member and provider experience. And we feel that through this interconnected approach, we can work towards a transformational future state where people can be at their best possible health, and data sharing is a crucial component to this. So for example, today we have many great quality management programs, quality improvement initiatives. We have a lot of great work taking place around quality accreditation and ratings, and we have a really nice quality incentive program. But in order for us to get to this transformational state where we have new tools, new partnerships, new services, sustainable innovation, and true value-based incentives, data sharing will be important for us to help bridge some of this gap. And I think data sharing will allow us to work more optimally, whether it's cross-functionally within and in between organizations, with our providers, especially in a more interconnected and impactful way, because in some ways, this is what will allow us to reach the highest quality of care for our members here in the IE.
Thank you. And Dolores mentioned it, but I just want to circle back to the P4P program you have, which is Pay for Performance. And you have a really comprehensive P4P program focused on hospitals, ambulatory practices, and IPAs, and it rewards those various provider entities for achieving different quality goals. And one of the innovations that you introduced was to include measures around data sharing as part of that P4P program. I'd like you, and this is actually similar to we're seeing a very similar approach in other places, in Arizona and Wisconsin, where either Medicaid programs or plans are introducing a data sharing component as part of their broader financial incentives for quality. So Ed, I'd like you to ask a little bit about how that works. How does this data sharing incentive work, and what impact it's had, and also how has it evolved over time?
Sure. Well, for us here at IEHP, we currently have an incentive program that you mentioned that is referred to as Pay for Performance, or P for P. And what this P for P program focuses on is specifically rewarding our provider partners for both improvement and attainment in providing high quality care to our members. We currently have several P for P programs that include incentives for our hospitals and our primary care providers, as well as our independent physician associations. And we started down this journey of data sharing and incentives around data sharing back in 2018 with our hospitals. So for example, in 2018, we started with awareness around data sharing and basic reporting. And we use that data in key use cases such as post-discharge follow-up. Then in 2019 and 2020, through continued incentives with our hospitals, we built upon our learnings to focus more on improving data completeness and actually expanded the data elements that were being captured. And the teams were using the Health Information Exchange hospital data to feed into medical management systems to support things such as utilization management in patient workflows for safer care transitions, and also use the HIE data feed to feed into our provider portals so that we would be able to inform our PCPs for more timely follow-up post-discharge. And in 2021 and 2022, again, focusing on the hospital P for P evolution, the goal has been now around improving the quality of the data based on the file types. And I think what's great about the hospital incentives is that 100% of our hospitals were connected at year one, and 96% of our hospitals from years 2 to 4 were and have been actively sharing emergency department and acute inpatient data. So that's kind of the summary of the evolution of our hospital Pay for Performance program. In addition to this, we're also really excited to offer a new incentive program that just started this year for our primary care providers. And the goal for this year for our incentive program for our primary care providers is to have them sign up and to begin report and share CCDA data that they have to the Health Information Exchange so that we can start using these data elements for HEDIS reporting or other quality improvement monitoring activities. And I think by having both our hospitals and our primary care providers share data within the Health Information Exchange, I think we're one step closer to having true longitudinal records that are impactful and beneficiary as we care for our members.
And I just want to say, I think there's a strong commitment in the Inland Empire to information sharing, but these incentives still get everybody across the line because hospitals and ambulatory practices have a gazillion priorities on their plate. And when you share data, it doesn't help you, it helps the other provider. So I think financial incentives like the ones IHPs put in place are a critical element to really accelerating getting everyone on board and sharing data in a consistent and high quality way that benefits the whole community and all patients. So I just kudos for doing that. So kind of a backdrop to a lot of what we're talking about is the movement from an acute care approach where you just treat patients as they come in to a proactive approach, a population health approach where you're scanning across your whole set of patients and really asking what's needed, not who's coming in the door. And so this population health, approach is really the backdrop of risk-based contracting like ACOs. It's also the backdrop of CalAIM, and it's what we're asking so many folks in the community to shift towards. And in a world where you're just treating somebody coming in, information is helpful, but in a world where you're accountable for knowing everything that's happening and who might be at greater risk, it's essential. And so I think the role of having the shared longitudinal record in a risk-based model or population health-based model, it becomes not a nice to have, but really a need to have kind of item. So I'm going to ask Judy and Dolores questions with slightly different flavors around the utility of this HIE, the tools and infrastructure for population health. And I'd like to start with you, Judy, and you shared with us that you've led on the whole person care efforts, which really were an important precursor to CalAIM. Can you talk just in a very kind of pragmatic, concrete way about how your team used HIE services to better serve the whole person care program?
Absolutely. So Riverside County, as was mentioned earlier, is a huge landmass county. And so in this very big geographic county, we've got 13 different community healthcare clinics. We also have tons of specialty clinics on site in Moreno Valley, where our medical center is. And so when we went live with whole person care, we placed nurses in all of the in all the probation and all the parole sites in the county, which are spread out throughout the entire county. So knowing that Riverside University Health System is comprised of the hospital and all of these community and specialty clinics, but that we only have one hospital, which is in Moreno Valley, it became essential as we were screening people coming out of incarceration. We were screening them for physical health and mental health, housing needs, the need to get onto Medi-Cal, and et cetera. And so as we screened for needs and we made referrals for meeting those needs, there were people that were out in Blythe and in Indio and clear down in Murrieta, Menifee area. And so it became essential for the case managers that we hired that complemented those screening nurses to be able to identify whether or not one of their enrolled clients, enrolled was people with multiple complex needs who need a little help to get back on their feet after they've been released back into the community. So we needed the ability to be able to see if a patient went to the emergency department or was an inpatient in any of the hospitals in Riverside and really in San Bernardino counties, because so many people coming out of incarceration are homeless or underhoused and spending nights at different friends' homes. And so they can be very mobile throughout both of our counties. So the HIE was spectacular in helping us be able to identify easily when our patients who were getting case management, who we were trying to keep out of going inpatient and to ED services and trying to keep in the clinic for a medical home and the appropriate care in the right place at the right time. So it was fantastic when I met Dolores Greene and she told me about the HIE, and I was so excited, and I took it back, and one of my internal medicine doctors implemented it right away for her complex patients. And then we dove in and we really did use it extensively and continue to use it. I took over admin oversight for the Health Homes program almost 2 years ago. So then we started using the HIE information around the ADT, admission, discharge, transfer data in both health homes and whole person care. So it's been spectacular for us to be able to help more than just that population that we would only know about that went to that Moreno Valley RUHS hospital.
Thank you so much. And you can see the loop, the connection between these items, because whereas IEHP is incentivizing those hospitals to join and share ADTs, and then those ADTs are essential in serving those high need Medi-Cal beneficiaries who are now going to be part of CalAIM. For you, Dolores, you approach this from a slightly different model, which was an ACO. You're an ACO leader in the Inland Empire. What are some of the ways in which you've been using HIE services to really be effective in that program? And what are some of the results you've seen? You're muted, Dolores.
My apologies. So as you said, we do have an accountable care organization. We have a contract with CMS for, the Medicare beneficiaries. We have about 10,000 Medicare beneficiaries in our ACO, so a significant size ACO. And what we obviously the goal is to increase, the quadruple aim is to, ensure we have quality care of patients while, reducing costs. And so we were looking at really readmissions and discharges. And one of our big focuses is on the 7-day discharge. And we would not know because, again, our ACO is throughout the Inland Empire, and we would not know where our patients were without having the manifest the health information exchange. So we utilize the daily alerts coming from the hospitalization. So either the patient is in the ER, has been admitted, or of course, discharged. And the discharge, we get every single day alerts for our participating provider practices. Our staff tears those reports apart, if you will, and then we connect with the provider's office with the patients that have been, their patients that have been discharged. And then they work with the patient, getting the patient in within the 7 days, and all of the criteria for the 7-day discharges. But just to give you an idea of the success that we've had, in 2021, so just last year, 68.6% of the patients who were discharged were reevaluated within 7 days. So that is a really high percentage. And just to give you an idea of the impact, for those that did not get a reevaluation within 7 days, the readmission rate was 25.5%. For those who were contacted, got in to see the doctor within the 7 days, the readmission rate dropped to 15.6%. So you can just calculate in your mind the amount of savings that were generated, if you will, to prevent those readmissions. But our program overall has had a 39.4% reduction in readmissions by using the alerts. We've had 3.1% reduction in ER visits and 5.3% reduction in ERs leading to readmission. And I throw those numbers out because I think everybody is trying to make sure that the patient is getting the right care at the right time and the right location. And to better care for these patients, we need to get them in to see the doctors and get the care that they need to prevent readmission. So without getting those alerts and the doctors having the tools to be able to contact their patients, know that they've been discharged, and if it's on a Friday, again, it doesn't matter if it's a Friday, Saturday, or Sunday, they are getting these alerts and they know to contact that patient to make sure whether it's 7 days or for CHF patients, we really look at day 2 and 3 because that's the a lot of patients get readmitted, over the weekend after day 3 being at home because they haven't controlled, their intake, their salt intake or whatever. So it really gives us an insight. Plus, these patients are everywhere, and it allows, if it's a new patient, the doctor is able to get history on the patient to be able to immediately start, a treatment plan for the patient. So there's so many pieces that MX has of the puzzle, but our biggest success has really been the discharge and the prevention of readmissions.
Awesome, thank you. You've been, I think, equally passionate about helping your providers, doctor practices in the Inland Empire really move into the next generation of healthcare. I would say you're as passionate or more so about that as you are about HIE. And I know one of the things you've launched recently is a population health institute that really trains and works with clinicians and their front office staff about how they can make this pretty massive transition. I'm curious, just tell us a little bit about that institute and how it works, and how does HIE fit into that picture, what you're trying to train?
So what we have, we call it an academy, and it's a 12-month program, and that the class meets for 3 hours once a month in person as a group. And then they have homework assignments that what they've learned that month in class, they have to actually implement that piece of population health in their practices, and that builds on each other. But you cannot do population health without data analytics and robust data analytics. And so, of course, population health is not taking care of the 30 patients that are on your schedule that day, because those normally are ones that are seeking care, right? It's the, other 1,000 patients in your panel that are sitting out there that you may not know about because they're not coming in. And so the importance of what we teach for the data analytics is you need to know your entire population. You need to know your diabetics. You need to know your CHF patients. You need to know those that are out there, and we kind of say a ticking time bomb that you may not be aware of until they're in the hospital and, sitting in a hospital with multiple chronic conditions. So we really focus on that. And one of our sessions, our monthly sessions, is focusing on, again, the data analytics. How do you use the HIE, for different pieces of it, new patients, existing patients, discharge, et cetera, putting together the Connect IE, the social determinants of health, again, looking at that, your entire population, and then focusing attention or part of your team care based on the needs of specific population. But a doctor may know their individual patient that's sitting across from them that day, but they probably don't know their population as a whole until they have ability to see this insight. And again, extremely important in being successful in population health.
Great, thank you. We're going to shift focus a little to CalAIM, and I know there are probably many people on the phone that are very expert, and maybe some people that are a little new. So I'm just going to spend a minute going over some of the basic kind of precepts of the program, and then we'll jump into how we can really ensure its success, especially through data sharing. So for many of you who know, CalAIM is a new initiative in the Medicaid program in California, which is called Medi-Cal. And it does a few things. One, it allows health plans to substitute social services for medical care. So a patient who might be underhoused could have access to housing counseling. And this, of course, is because of the very, very strong association we see that many of the factors that contribute to health are not health care. There are things in the rest of our lives that affect it. So one thing is that there are going to be a whole bunch of new partners, community-based organizations who are providing those kinds of social services, whether that's housing or food services or other kinds of services. Secondly, it puts in place a new service called enhanced care management, and that's really a care manager on steroids who's going to be able to really comprehensively support those higher risk individuals, knowing what all of their needs are, doing the social risk assessment, helping make the referrals to those community-based organizations, being able to understand the full spectrum of the clinical needs as well. And so that's another component that is being implemented. And finally, both plans and the state will be implementing, as we've been discussing, population health management infrastructure that can support all of these various components that are being rolled out with CalAIM. Now, the program just launched in January, and I think everyone is running so fast trying to get the pieces in place. And the biggest initial push was really to get those contracts in place with those community-based organizations who we've never worked with in a formal way before, right? So that was a big push to say, who are those organizations? How do we support them in even billing? Who are these enhanced care management providers going to be? So I think a lot of implementation legwork has been the focus over the last couple months. But I think as the dust starts to clear and people look out to the next 6 and 12 months, one of the next phases of the work is really going to be how do we ensure the right kind of data sharing between those enhanced care management providers and the rest of the clinical team. And then beyond that, what kinds of data sharing will be needed with these social care providers. So I think it kind of, some of what needs to happen is really making sure those basic pieces we've already been working on are in place for everyone. And then another thing is how do we actually enable data sharing with a much broader spectrum of the community than we've ever had before. So it's a very exciting time for all of us. It's also hard because there's so much to be done. It's sometimes a little bit hard to know where to start. So as smart leaders, I'm going to ask for your guidance, both Dolores and Judy. I'll start with Dolores. What is it going to take for this program to really be successful, not just right now in this immediate implementation, but really over time?
I think one of the first baby steps is providers need to know their patients, and so a provider knows the patients that are in their EHR, right? They have the information on their patients, but that's not their entire attributed lives. And so, say a provider has a panel of 2,000 patients, but maybe 400 of those are in their EHR because they come in mostly in this the Medi-Cal world. There's a lot that may not seek the care, and so they don't know those patients. But now through MX, the health plans are submitting patient rosters, if you will. And I'll give an example. We have a practice here in Riverside, and they are a large Medi-Cal practice. And I was talking with one of the physicians, and he said, we have 350 homeless in our panel that we had no idea about. And so they actually have we have a population health fellowship too. And so one of our fellows, it happens to be in this practice. So she is now concentrating on that 350 homeless population that they did not know. Obviously, those patients had not been in to get care. And so using MX, they've been able to track the history of that patient. Where have they received their care? What emergency rooms have they gone to? Looking up even demographic information, phone numbers, last known phone numbers. And we know they're homeless, but homeless can mean many things, right? Sleeping on somebody's couch or, whatever. So it's putting pieces together. And that's where the HIE has been really helpful for just identifying who these patients are, how we might get hold of them, trying to build a profile, if you will, to begin, bringing them into their fold. So that's just one example. And I think one of the hardest things is connecting with some of the patients that are now going to be in the CalAIMS program to get them into the fold of healthcare. And since they're being assigned to, ECM practices, whether they're private practices or within the county health system, how do we get to these patients? And you have to be a detective and utilize every tool that's out there. And having the HIE have demographic information because they've gone to an emergency room or wherever, that helps tremendously.
Judy, having worked in this space now for several years, what's it going to take for CalAIM to really be successful from your perspective as a leader who's worked in health homes and whole person care?
Yeah, so not only do we have a large population of what we call assigned not seen, as Dolores was explaining, there's another factor that I think that HIE is going to be able to help us with all patient care, not just the CalAIM ECM population that we might case manage, but I think the other really big improvement that I see as needed in the healthcare arena is when we have patients that are seeking and accessing services from community partners county partners. Sometimes there are 5 or 6 people providing different types of care to a single individual. And the ability to be able to see one simple example, their motivational interviewing goal. So while we as healthcare providers have goals around people reducing weight, getting their sugars in line, and impacting their hypertension, there are other things that patients really want to focus on. And once they can focus on that with some help from a case manager, they're more likely to have more trust in that case manager and then start to weigh up the goals that we as healthcare providers have. So I think that what I see happening a lot, that I see hope for through an HIE, is everybody is asking the patient the same questions. None of us are communicating with each other, even when we work in the county in just different departments. And I think that comes across as a lack of caring, which it truly isn't. It's just that we are not good at the ability to data share with every partner that we have our patients accessing care from. And so I don't want to dive too far down a rabbit hole, but the Connect IE platform, I'm really excited about the integration that's going to be happening with that, because I was there when we selected our Aunt Bertha platform, and that has been wonderful, because at minimum now the care management team and each of the clinics can see through that Connect IE platform, oh, somebody was referred over here. Now I can actually check in on that patient. I didn't make the referral, but they got a referral. I need to check on them to make sure they showed up. So I think it's just going to take a little more freeing up of data sharing ability. I think for a long time we've used HIPAA and 42 CFR as excuses not to treat a whole person as a group of people surrounding that person. And I think we're going to have to get to some better data sharing abilities than what we have currently.
That's a great way of putting it. I wanted to mention also a couple of things that we're partnering with all of you guys on from the HIE perspective to enable the success of CalAIM, just adding in those elements. So one thing, and I think you mentioned it, both Dolores and Judy, is we realized a couple of years ago that it was really hard to track what services people who might be experiencing homelessness are kind of how to catch them and support them, for instance, after an ED visit. And so we actually worked with this group and also with the Hospital Association to have all hospitals do a uniform way of coding for somebody experiencing homelessness. And that means that the ADT data carries a ton of important insight around health conditions and all of that, but also important information about that person's social experience and what they're going through. And we didn't need to implement a new platform or a new technology. It was really as simple as all agreeing on a common way of doing something, which I thought was awesome. Secondly, we've all experienced a problem where we want to reach out to patients, but don't have their contact information. And we're going through a pretty intensive analysis right now to say, what's our best contact information? Because we get contact information from all of the clinical sites and from health plans. But what was happening is the health plan contact information might be older, but it was when we got the new claim in, it was replacing the newer information we got from a clinician. So something very pragmatic and simple is to start creating more of a hierarchy, saying, oh, maybe contact info from a clinical site is a little bit more up to date because it's probably coming from a patient registration event. Or let's give everyone all the numbers. And that's frustrating, but at least you have all the information. So contact information is gold, right? And we're really trying to be thoughtful about that. Lastly, race and ethnicity. You know, we all are so determined to recognize and address the inequities that that have been very present in our health system. But you can't improve what you can't look at and you can't see. And so we just did a very comprehensive analysis and found that we have race data for about 40% of the patients in our 30 million records. Which isn't 10%, but it's also not 80%. And so we're also now going out and asking comprehensively, how can we be sure we have that that important insight for at least 50% or more by the end of the year. And we have a lot of very creative strategies we're going about to do that. So I think what you'll see with many of these questions is the solutions are often very low technology, but they have to do with building on the cross-organizational collaboration, because we cannot get to these goals without working together and collaborating. So I love where Dolores started earlier, which is really building that connection of joint intent and purpose. Because if we're going to ask hospitals to code a certain way for housing status, we need a venue and a way to bring those people together. I'm going to ask Dr. Juhn the last question before we open up for Q&A, and really around equity. And I know you you sit on the new Health Equity Committee for DMHC, and you're also thinking a lot about that in the context of your quality goals. And I'm just wondering, what are some of the opportunities you're really excited or intently focused on to tackle health equity with data?
I think you mentioned a really important topic. And I think, for us here at IEHP, along with many others on this call, I think we're all collectively committed to improving our members' access to equitable healthcare. And I think it's important to recognize that both the Department of Managed Healthcare and the Department of Healthcare Services have put this front and center, because it represents key areas of work that we're aligning to. For example, the Department of Managed Healthcare, as you had mentioned, just created a DMHC Health Equity and Quality Committee. And it's made up of different stakeholders with the goal to make recommendations to the DMHC director for standard health equity and quality measures, including annual benchmarks and standards for those benchmarks for assessing equity and quality in healthcare delivery. And the committee is meeting monthly, and the output of this committee is to make those recommendations. I think in addition to what the Department of Managed Healthcare is working on, the Department of Healthcare Services also released a comprehensive quality strategy with guiding principles that are focused on eliminating health disparities through anti-racism and leveraging community-based partnerships, having transparency and accountability and member involvement, and also a data-driven improvements that address the whole person. And this approach builds upon the population health management framework, which is the cornerstone of CalAIM. But I think what these examples, or I guess both these examples, are really emblematic of is the importance of leveraging the promise of data sharing, especially when it comes to supporting these bodies of work, because you can't address equity, especially health equity, without understanding what the data is sharing with us and how to appropriately process that data in appropriate ways so that we can address the inequities that we're seeing in healthcare today.
Great, thank you. So please and put any questions you have in the Q&A, and we'll also try to follow up with you. If we don't get to all the questions, we'll keep the Q&A and just see if we can follow up offline. One question for Dolores. I think people are fascinated by the Population Health Academy. So can you say a little bit more about who participates in that?
Sure. So it's a year-long program, and we keep the class limited to 12 physicians, but we invite the physicians to include their team members, because again, population health is a team-based sport, right? You have to have your team supporting and seeing the patients, and we help them identify who should be seen by who's appropriate to be seen by a physician versus a nurse practitioner, a physician assistant, or a PA, or who beds the patient, right? So the MAs, everybody plays a role. So the physician is the primary participant, but we encourage them to include their quality improvement staff, or maybe some other team member that would get value, because again, this program teaches them to go back in and implement population health into the core of their practice.
Awesome. And there's some questions around, I want to follow up on a thread that connected Dr. Juhn and Dolores, which is that there's now an incentive program in the Inland Empire for small practices, that primary care sites to join HIE. And you said earlier, Dolores, that one of the results of the EHR incentive program is you have all of these different EHRs, right? So we might have 1,000 practices on a couple hundred different EHRs. And I know we're partnering with both IHP and with you, Dolores, on how do we actually effectively recruit and onboard those small practices. And we also had great experience in doing that through CalHub. But you're leading that work. So I really want, I think one of the big questions that's come up in the data sharing framework conversation is how do we make sure that those small practices aren't left out, and how do we really support them in onboarding to HIE? So I'd just love to hear you say a few words about how that works.
Okay, well, our last group, if you will, here in the Inland Empire is really the ambulatory space. And, you know, the larger groups have embraced HIE and they are on, but the smaller practices have very limited resources, very limited knowledge in the IT world. And so they're a little bit afraid of it. And then they look at what is it going to cost me, even though MX doesn't charge for the ambulatory providers to participate in the HIE. Sometimes their EHR vendor can charge a significant amount of money. And so I think these, the ambulatory project going on with IHP that is funding MX to help, you know, work directly with the EHR vendors. So there's not a financial roadblock as well as a technical roadblock, if you will. And that makes the difference is there's not enough financial resources in small practices that allow them, you know, do I pay my staff or do I go on an HIE? We don't want that choice. And so having the funds and the ask for the state budget of the 95 million to help all, you know, ambulatory providers or other providers go on to, you know, an HIE throughout California, that's so important because you're not going to be able to get the providers there without technical assistance and some funding assistance. So very, very important.
Great. And one of the questions that came in was a very concrete one, which is how much does it cost to join the Manifest Medics HIE? And I would say as a ambulatory practice, as Dolores said, there are no fees. And not only that, at least MX has been subsidizing the EHR fees that are often directly charged. We do have subscription fees for hospitals and health plans, but those small practices often lack the financial ability to join, but yet they benefit, the patients benefit so much. So that's the structure as it stands today. Well, we're going to be wrapping up with the last question. I can't believe the hour is almost at a close. And the last question I want to ask each of you, just to respond maybe in 30 seconds or so, which is if you had to choose one thing that we have to get right in the state of California that you've learned from your hard work in the Inland Empire, what would it be? And I'll start with Dolores. I'll go Dolores, Judy, and then Dr. Juhn.
Well, you know, my focus, obviously, because of the hats I wear, is the importance of getting the ambulatory data in the HIE to be valuable to everybody. And we can't do that without, you know, methodically moving these practices along. So that's where I think we can make big inroads into the future, is not just you know, small practice providers, but SNFs and all of those ambulatory pieces that support the patient.
Wonderful, thanks. Judy.
So I would say a truly integrated care plan with all people who are providing care to a single individual, one that we can all see in real time and update in real time so that none of us are duplicating efforts, which we do frequently currently. And a second thing is off topic about data sharing, but I would encourage our state to consider suspending Medi-Cal and not removing it annually, that is.
Okay. Dr. Chin.
I think data sharing incentives at the statewide level is important. We've seen some of the movement here in the Inland Empire through our incentives, and I think it could be scaled throughout the state. And with the scaling, I think we need to find a way to ensure that data sharing is part of the provider workflow. Our clinicians, whether they're in the hospital or our patient setting, need the right tools, infrastructure and resources to make this successful. And in order for them to climb the hill of data sharing, we need to support their will and skill as well. So I think that's where the incentives and the support go hand in hand.
Awesome, thank you. And I'll just maybe mention one other thing that Dolores touched on. We have here, many of the organizations across the state are supporting a budget ask. We have HIE signed up to support medical organizations like Dolores's and plans like IEHP. And this budget ask would be for $95 million that would be generously matched by the federal government. And it would support the kind of data sharing incentives that Dr. Juhn talked about, but also the kind of HIE infrastructure and services that are serving population health, ACO, CalAIM, and all the other things that we're talking about. And I think it's an example of really what we're seeing as a collective need and a great collaboration to say, like, let's put our money where our mouth is and really build this infrastructure as important as railroads and roads. It's what's going to allow us to improve our health system, and let's see if we can really invest in it for the next decade. So it's been delightful to have all of you on. This will be the first of a robust series of webinars. I'm so grateful and thankful to Dr. Juhn, Judy, and Dolores for joining today. And we will copy your questions, and if we didn't get to them, we'll try to follow up offline. But thank you again so much, and have a wonderful rest of your day. Take care, everybody.
Thank you.